Assalamu alaikum. This is the second part of a series of presentations on oral ulcerations. This presentation would cover recurrent oral ulcers. Ulcers can be broadly classified into acute ulcers that would take usually less than 2 weeks to heal, and chronic ulcers that would take more than that, and recurrent ulcers. In this presentation, we shall cover the recurrent ulcers, diseases, systemic or local, that can cause recurrent oral ulcerations. Four of them are commoner: the Aphthous ulcers, the Herpes Simplex and Herpes Zoster ulcers, the traumatic oral ulcers, and the oral allergy or hypersensitivity reactions ulcers. And there are the group of less common conditions, including Behcet's disease, cyclic neutropenia, Reiter syndrome, and herpes-associated erythema multiforme. Recurrent aphthous stomatitis is fairly common. In a USA study, more than 50% of healthy students had positive history of recurrent aphthous stomatitis. There is a female predilection. The first episode of aphthous ulceration usually occurs in the second decade of life. It affects mostly the non-keratinized mucosa of the oral cavity in healthy subjects, including the buccal mucosa, the oral vestibule mucosa, the undersurface of the tongue, and the floor of the mouth. But it may also affect the keratinized part of the keratinized mucosa of the oral cavity in patients who have some immune deficiency. Aphthous stomatitis starts with a prodroma of a burning sensation that lasts for few hours up to 48 hours before the ulcer actually appears. When the ulcer appears, it's painful. There are usually multiple ulcers, symmetrical, of almost the same size, round or ovoid, and are yellowish white in color. They are surrounded by an erythematous halo. The predisposing factors include things like familial tendency, local mouth trauma or stress. Some patients may be sensitive to other agents, including, for example, sodium lauryl sulfate, and they would respond to SLS-free toothpaste. Ulcers can be classified into minor, major, and herpetiform. The minor aphthous ulcers were first described in 1898, and they are by far the commonest of the three types of aphthous ulcers, accounting for about 80 to 90% of all the aphthous ulcers. They would measure less than 5 millimeters in diameter, usually between 2 and 3 millimeters, and at any one time a subject could get as many as 6 of them at the same time. They typically heal spontaneously within 10 days or so. Aphthous-like ulcers can occur in other systemic diseases, such as inflammatory bowel disease, celiac disease, and nutritional deficiencies, immunoglobulin A deficiency, Magic syndrome, the mouth and genital ulcers with inflamed cartilage disease. They can also occur in association with the use of certain medications, including non-steroidal anti-inflammatory drugs. Major aphthous ulcers were described a bit later in 1911. They would account for about 10% of all recurrent aphthous ulcers. They are bigger in size, measuring 1 to 3 centimeters. They are also deeper and would take longer to heal, up to 6 weeks or even more. And when they heal, they can heal with scar tissue, in contrast to the minor aphthous ulcers. Sometimes the major aphthous ulcers could affect keratinized as well as non-keratinized areas of the oral cavity, including the dorsum of the tongue and the palate as well. They can be associated with considerable pain and malaise and difficulty in swallowing. Laboratory evaluation would be required if the episodes become very severe and if the lesions begin to show after the age of 25 years, or when there are general symptoms accompanying the lesions like fever and malaise and lymphadenopathies. The herpetiform type of aphthous ulcers account for about 10% of the recurrent aphthous ulcers. They are very small, tiny ulcers measuring about 1 to 2 millimeters, but they come in quite substantial numbers, sometimes up to 100 lesions at the same time. They cluster into a same area, resembling very much the type of ulcers associated with viral infections, hence the name. They can be very painful. They may fuse together to form a larger ulcer with a scalloped edge, as seen in viral infections, and about a third of them would heal with scar tissue. The treatment for aphthous ulcers is best initiated as early as possible. The ulcers may be covered with steroid pastes, things like 0.1% triamcinolone acetonide. It's best to dry up the mucosa around the ulcer before the application of the paste, so as to allow it to adhere to the mucosa. Antimicrobial mouthwashes like chlorhexidine, povidone iodine, or benzidamine can also help in preventing secondary bacterial infection. Major aphthous ulcers seen in conditions like, for example, HIV disease may be treated by intralesional injection of triamcinolone, while the widespread resistant disease, corticosteroids systemically can be tried, perhaps coupled with steroid-sparing drugs like azathioprine. Other medications, including colchicine, dapsone, pentoxifylline, have also been used in the management with varying success rates. Another common cause for oral ulcerations is the recurrent herpetic stomatitis. Herpes simplex virus can establish itself in the trigeminal ganglia and periodically reactivate, causing recurrent herpetic stomatitis. There are two groups of such disease. The first is recurrent herpes simplex labialis, which is more commonly seen in healthy subjects. Small vesicles would form and then they will readily rupture and leave around painful ulcers. Sometimes these ulcers can coalesce and form a bigger scalloped edge ulcer. The other type is the intraoral herpes. Recurrent intraoral herpes is more common in the immunocompromised patients, but when it affects an immunocompetent person, it tends to affect mostly the palate in clusters of vesicles and that eventually form ulcers, and sometimes they are unilateral rather than diffuse. Recurrent herpetic stomatitis can be triggered by things like physical or emotional stress, ultraviolet light, cold weather, hormonal changes, upper respiratory tract infections, and trauma to the lips or the mouth. Symptomatic management would include the application of ice or lanolin, but the active treatment would include acyclovir application 5% every 2 hours from the very start until the lesions subside. Systemic acyclovir or other antiviral medications should be considered if the disease is severe, including acyclovir 200 milligrams 5 times daily for 5 days, and other antiviral medications as well. If elective dental treatment could be deferred, that is better in order to avoid dissemination of the virus as an aerosol during an active flaring up. Another viral stomatitis is caused by the Herpes Zoster infection giving rise to shingles. This is caused by reactivation of the varicella zoster virus, particularly as a result of immune system deficiency. Sometimes it can happen spontaneously in the elderly. It affects mostly the hard palate, the gingiva, or the tongue, and is usually preceded by unilateral pain prodroma. The vesicles form first along the course of a nerve, in this case along the greater palatine nerve. They readily rupture to cause small ulcers that may coalesce to form a larger scalloped edge unilateral ulcers. This is the main distinguishing feature, is that they are unilateral. They are self-limiting and they heal within less than 2 weeks. Erythema multiforme is an acute hypersensitivity reaction with mucocutaneous manifestations. They are triggered by either some medications, including things like cephalosporins, quinolones, analgesics, and non-steroidal anti-inflammatories, and penicillins, and sulfonamides, or several infections, mainly herpes simplex virus and Epstein-Barr virus, cytomegalovirus, and varicella zoster, and others. The skin lesions characteristically are formed of target lesions. They look like targets. Here, target lesions are formed of red macules, so papules and vesicles that coalesce to form larger plaques and form these target lesions. They are diagnostic. In the oral cavity, they mainly affect the lips and the buccal mucosa. Again, they are formed of red erythematous macules, followed by formation of bullae, and these bullae would rupture and form large ulcers. These ulcers may coalesce to form larger scalloped edges, big ulcers on the lip or the buccal mucosa. The diagnostic feature is blood incrustations over the lips. This is diagnostic. Erythema multiforme has a slight male predominance. It affects more the age group between 20 and 40 years and affects mostly the lips and the buccal cavity and the tongue. It forms large and confluent ulcers, multiple ulcers. They often are mixed with conditions like herpetic gingivostomatitis, but the ulcers here are much larger. They can be preceded by prodromal symptoms in the form of fever, headache, lymphadenopathy, and sore throat, and these prodroma may be noticed a week before the start of the eruption in the skin and the mucous membrane. Behcet's disease is a systemic immune-mediated vasculitis characterized by recurrent oral and genital ulcers, ocular inflammation, and skin lesions. Affect mostly the age between 25 and 40 years. It's rare to affect subjects before puberty or after their sixth decade of life. It affects males and females equally. It forms Aphthous-like ulcers, more similar to the major type of Aphthous stomatitis, affecting the oral cavity and the pharynx. The recurrent and painful oral ulcers are present in more than 90% of the subjects presenting with Behcet's disease. Oral and genital ulcerations is not restricted to Behcet's syndrome or variants such as the MAGIC syndrome, the mouth and genital ulcers with inflamed cartilage. Other systemic mucocutaneous disorders could present in the same way. The pathology test was at one point thought to be a diagnostic feature of Behcet's disease. It is a hyperreactivity to intradermal needle prick. It was tried in several places, including Turkey and Japan, and was found useful, but apparently the British patients almost invariably give a negative result to the intradermal needle prick test. Diagnosis of Behcet's disease can be based on recurrence of Aphthous-like ulcers at least 3 times within a year. These ulcers will be more like the major type of Aphthous ulcers, large ulcers, deeper and with longer duration. They are also more tender. Along with 2 other manifestations of the following, either genital ulcers, ocular lesions in the form of uveitis, either anterior or posterior, and vitreous cellularity, or retinal vasculitis, or skin lesions like erythema nodosum or pseudofolliculitis, for example, in a post-adolescent patient without any steroid treatment. The international criteria for Behcet's disease came up with a scoring system, and diagnosis the disease would depend on obtaining 3 points from the following: 2 points if there is genital ulcers or eye lesions each, and 1 point if there is skin lesions or oral aphthous or vascular lesions. Several medications were tried in the treatment of Behcet's disease, including corticosteroids, azathioprine, thalidomide, and dapsone. Also, things like colchicine and cycloprine had also been used. It was found that the anti-TNF-alpha infliximab has actually a good efficacy in controlling the recurrence and the resolution of the oral ulcers. Topical corticosteroids are not optimally effective against the oral lesions. Another cause for recurrent oral ulcers is the repetitive traumatic oral ulcers, the bite injuries seen for example, in the autism spectrum disorder subjects or patients who have intellectual disabilities or in the context of a seizure. It can also be induced by ill-fitting dental braces or aggressive tooth brushing or a damaged tooth enamel or deformation of the tongue. Sometimes also bruxism can induce recurrent oral ulcers. Traumatic oral ulcers are most commonly in the buccal mucosa, 42%, or the tongue, 25%, or the lower lip, just 9%. The edge of the ulcer are either raised up and reddish, or they are white and keratotic. The base of the ulcer is necrotic and is covered by a pseudomembrane that can be easily wiped off. They can be painful for the first 3 days. They usually resolve within 10 days and may persist longer if they are on the tongue. Cyclic neutropenia is another cause of recurrent oral ulcers. This is an immunodeficiency syndrome characterized by irregular and periodic oscillation in the numbers of circulating neutrophil. These levels will drop every 21 days and last for 3 to 6 days in the reduced numbers. This is usually asymptomatic, but sometimes during the phases when the neutrophils drop, there may be an episode of fever of unknown origin, gingivitis, stomatitis, or Aphthous-like ulceration, like a major Aphthous ulceration. They can also have aggressive periodontitis. The condition starts in childhood and affects any oral mucosa that's exposed to trauma. The episodic ulcers have a reddish halo around the ulcer with a concomitant fever, gingival inflammation and recession, and systemic infections like cellulitis or perirectal abscess or severe systemic pyogenic infections elsewhere. Multiple oral ulceration can also be caused by allergic reactions or hypersensitivity. Plasma cell stomatitis is an example of contact stomatitis that can be caused few days after exposure to certain antigens. They mainly affect the gingivae, the buccal mucosa, and the buccal sulcus, and they cause multiple shallow ulcers. They start with erythematous macules of the gingivae, some desquamation of the gingiva, desquamative gingivitis with epithelial sloughing, and superficial multiple ulcers of the gingiva. They are self-limiting, but the use of anti-inflammatory agents can help in diminishing the healing time, and also patients would require pain control. Reiter syndrome can cause multiple recurrent oral ulcerations. It starts with a history of bacterial gastroenteritis, urethritis, conjunctivitis, and arthritis. It causes multiple ulcers on the palate or the tongue or the lips. They are superficial and Aphthous-like ulcers, sometimes with opaque vesicles as well. And finally, control of the patient's symptoms would be required in all the cases of acute oral ulcers, even before a final diagnosis is established. These would include things like saline mouthwash, topical analgesics or anti-inflammatory such as benzathymine mouthwash or spray, antimicrobial agents like chlorhexidine mouthwash, spray or gel, barrier paste over the ulcers such as carmilose gelatin, or topical anesthetics such as lidocaine spray or ointment. and sometimes systemic analgesics or antibiotics or steroids depending on the patient's condition. It's also useful to reduce or stop any smoking, alcohol consumption, spicy or acidic food or drinks, and the conditions that generally predispose to oral ulceration, such as iron deficiency, anemia, vitamin deficiency, should be also excluded or corrected. By this, we come to the end of this presentation on recurrent oral ulcerations. Assalamu alaikum.